Hello, my name is Christina Bethell. I'm a professor at Johns Hopkins University Bloomberg School of Public Health, and I direct since 1996 the Child and Adolescent Health Measurement Initiative and am a NOVA Institute scholar. And today I am here to present to you remotely a presentation called Family-Centered Digital Tools to Strengthen Cross-Sector Coordination in City and County Health Systems. So let me go ahead and get started with our presentation today. So first of all, just to say a little bit about the CAMI, we've been around since 1996 when there was no data to really tell the story about how children, youth, and families are really doing in the country, and to be able to then create data and tools for local areas to really do the magic only they can do, which are those transformational partnerships that can start to implement and get feedback loops on how we're doing in actually improving well-being and flourishing for children, youth, and families in local areas. We also lead the Data Resource Center for Child and Adolescent Health, childhealthdata.org. And a lot of the data I'll be showing with you today is available for every state in a point-and-click way. So I just like to make sure you have that resource at the outset. So I don't have anything to disclose or conflicts to resolve. However, I do like to disclose I have a perspective, which is I feel that we do have sufficient science of early and lifelong health, even amid adversity, to translate this into policy and culture and practice. And doing that really creates city and county partnerships to take the lead. I got my start when I was 15 working in my own community, and I fell in love with this model a bit later called the 8 Conditions of the Competent Community, which I thought was so resonant with what my experience had been working in community. And how can we create a shared commitment to well-being, understand each other, get on the same page in what we're talking about and how we measure it, and basically create the machinery to really facilitate interaction decision-making over time. So that was my goal, and got an early start in my career looking at community partnerships and what was making them work or not in local areas. And even back then, we had all these elements of a paradigm shift we're talking about now, like being disease-oriented to health-oriented, making sure there's explicit shared goals and accountability, community and person and empowerment focused versus just system focused. And then the health assessments that we know are going on multiple levels in cities and counties. And how can we do those in ways that really translate into change? But I ran into a barrier, which was there wasn't really actionable data about children, youth, and families in the country, birth and death records and things like that, but nothing really to help us understand how we're doing and what we could mark our progress on. So I got very involved in creating measures and data, much to my surprise. And tried to really do it in a systemic way where we had data nationally, state, local, some of it was shared so we could really track and coordinate in terms of our shared goals to push that down across our systems and services. So they're sharing some of those outcomes and performance measures and ultimately really anchored to child and family and youth well-being. So that was the goal. And we actually made some success in creating frameworks that really focused on creating information that could also engage families, was from families and communities, so that as we know, the only way to really change anything is effective engagement and partnership with people themselves. And so much of what we do is about that. So that's been a little bit of my journey. And we had enough success that we were able to create the National Data Resource Center for Child and Adolescent Health, where about 15 of the Healthy People 2030 objectives for city and county and state public health come from this survey. And here's just a list right here, but many of them relate to primary preventive services, which is the focus today. We've got lots of frameworks as well, and I'll be sharing a little bit about frameworks, but mostly I'm going to be doing a deep dive into some of the tools that you can use because you're so familiar, I'm sure, with many of the frameworks. So I'll be going over the cycle of engagement well-visit planner approach, which subtitle is Real Engagement for Real Health, and leveraging the already existing well child visit and using a through any door approach. But first, let me do a little bit of synthesis of some of the science behind this and the progress we've made that really hopefully motivate us to take quick action to focus on positive health flourishing, school readiness, things like that, not just getting rid of bad things. I'll go over the cycle of engagement, well visit planner approach with you, its elements and structure, how it works, and then share a little bit more about implementation. And there's a lot more resources where this came from. So, in terms of the synthesis of the science, when I was born, we actually had a lot of thoughts about biological determinism. So, there wasn't a lot we could really do. But we really know now that our ecology really is driving a lot of our development in our brain and our gene expression and things like that. So, the social, physical environment, things that we can impact, are very related to our biology and health and development. And so this is inescapable, not argued about anymore. However, we didn't have data to find out, well, how are all these factors actually working? And so we worked hard to create robust evidence-based social health risks like economic hardship, food insecurity, community violence, not sense of belonging, and then also relational risks. And we wanted to separate them because a lot of times we put them together and look at social determinants, assuming it's actually addressing those relational health risks, but we didn't really know. It makes some sense, but does it really work? And so was very excited to finally, after maybe decades, have all the data in the right place to create this whole child risk index to help us understand that. Finding about 52% of US children actually already have some of these evidence-based risks. And then how did that play out across their actual health? And so this is just a little slide making a key point I want to make with you today, which is that not only is the prevalence very high for children with medical, mental, developmental health conditions, but they're very related to these social and relational health risks, such that even with no social health risks, children that have two or more relational health risks, ACEs and parents who are struggling to cope, things like that, have over 2 times the rate of medical, mental, or developmental health conditions. Now, there's a lot of research showing what the pathways would be for that, the neurobiological pathways, the psychological and psychosocial pathways. But when we get both of these together, like we have in many of our communities, those social risks and relational risks, it goes up to 70%. So it's all of us. It's really all of us. And it's not just social risks, it's also relational health risks. And 60% of children with relational health risks that pack a very big punch on early childhood development and health throughout all of life, like ACEs, actually do not have social health risks. So we really have to come in together for a full population approach. And just for fun, I put together a little slide to visualize this for you. The number of children meeting any of these criteria on the risk index would fill 104 national malls and would go the distance of children filled with school buses between Miami, Florida, all the way to Anchorage, Alaska, distance-wise. And we do have this data on our child health data website for all states. So really wanting you to see that because it really gets behind why we need this integrated systems approach. But we need an integrated system approach that's going to go the distance to promoting positive health and well-being. We haven't really done such a great job getting rid of illness or adversity, but maybe by promoting flourishing, resilience, and well-being in the ways that we can, even amid adversity, we will actually be able to turn the tide on the adversity in a more powerful way. So the science is very strong to introduce a flourishing paradigm, which is what all the work I'm going to be talking to you is anchored to. And it flips the narrative from just proactively to proactively promote positive health and healing, recognizing that positive health and healing and flourishing is on a dual continuum to health. And many without any risk or illness at all are not actually flourishing or well. And many that do have risks and illness are well in these ways that are of the living and relating self, being able to learn and be resilient and have positive relationships and a sense of meaning. These aspects of flourishing are possible for people across the continuum of illness. And my theory is that by promoting that, we'll really be able to improve in ways that help us get up underneath the risk and illness that we've had such a hard time doing. So quickly, the National Survey of Children's Health has a brief child flourishing index. All the measures have to be brief. That's true for cities and counties too. It's expensive to collect data, so we do a lot of fancy dancing to try to figure out what's the lowest number of items that really reflect the science we're trying to base our measures on. So we have for early childhood and for school-age children a set of metrics that reflect healthy executive function and brain development and attachment in young children. And what we find is that, first of all, there's a lot of variation across states. So we have a lot to learn from each other, even within a state. There's a lot of variation across cities and counties. So variation's information, which can create learning if we use standardized measures, but not if we don't. So we have a lot of work that we can do because we have evidence-based strategies for improving flourishing for young children and youth and adults as well. But when we don't achieve that, things like school readiness and that really project into lifelong well-being, economic and otherwise, is very impacted. So on the right here, you can see that children who only meet 0 to 2 of these flourishing criteria have a rate of school readiness of 22% versus 74%. So it's a strong indicator for things like school readiness and much stronger than even measures of ACEs and risk. So I want to leave you with some of this data. This is just showing by item a little visual of what happens for within an item, like, for example, bouncing back and quickly when things don't go your way, like daily challenges, with very dramatically different school readiness rates for those who say sometimes, never, usually, or always. And always is really the goal. Because always isn't always. When people say always, they usually mean usually and always. So it's a positivity reporting on a lot of these measures. So then the question arises, well, what is it that's impacting this the most? Is it the social determinants? Is it those family relational health factors? And of course, we got a big signal that it was family relational health and things like that, but not just the negative, also the positive. So we created something called the Family Resilience and Connection Index. And this actually looked at all kids across all levels of ACEs, 0 to 4 or more, all levels of poverty to 400% of income, all levels of chronic conditions, complexity, and levels of complexity of disability, and basically showed that strong family resilience and connection was very associated with mitigating the impact of these risks and promoting flourishing and then school readiness for and school engagement for children. And so this was at all levels, showing that a whole child focus means a whole family focus and a whole community focus, which of course many of you already know. And these are things like whether families feel hopeful when things are hard, feel they have strengths to draw on, stick together to solve problems versus isolating from each other, and really that keeping the connection alive. So only about half of children in the country met high levels of these criteria, which is worrisome. But when they did, they had a lot higher flourishing and school engagement and success, even at very high levels of diversity, like 4 or more ACEs. So building on this, we created a positive childhood experiences measure, which is adult reported, like ACEs is. Looking back on your childhood, when you think about your experiences, which is really what matters, that's what's knocking around in your nervous system and body, is the actual lived experience. Not just whether something was in place. So there's a lot of kids with protective factors, but they still don't have this experience of safe, stable, nurturing relationships, which is really what's packing the punch. So we did create an index, tested it, had no idea how it would work, but it turns out it's a dose response effect of predicting lower mental health, higher relational health as adults for adults across all levels of ACEs. So adults with 4 or more ACEs were 72% lower odds of having adult depression or poor mental health if they had higher levels of positive childhood experiences, which operate, again, on a dual continuum. They're not the opposite of ACEs. No ACEs doesn't mean that you have positive experiences. It doesn't mean you have proactive, safe, stable, nurturing relationships. It means you just don't have the risk. So we, again, are seeing over and over that we need to look at positive and relational health proactively, and then work on raising that as a way even to both mitigate the risk, but maybe get up underneath it and prevent it over time. So this is a paper published in JAMA, and there have been many, many, many papers since, mostly repeating that only about half of adults looking back on their childhood had these strong positive experiences. And then they're the adults that are caring for our kids. So we need to really look at the well-being of adults as well if we're going to help our kids. But keep in mind, it's a paradox. Again, it's how we meet each other when things are hard that actually has the biggest neurobiological benefit. So, how did I feel safe to talk about my feelings when things were hard? Did I feel supported when things were hard? And that's something we can do right now, in a way, leveraging what's difficult to create the connection and relational health that we really, really need to thrive in our bodies and our brains and in our hearts and minds. So I would say all this has taken us so many decades to do, and we're ready to soar, but it depends on translating this evidence into the ground. And there's a lot of really perfect storm elements in place with so many decades of research and aligned recommendations. And one of the biggest alignments in those recommendations is to really focus on primary prevention at all levels in every community. And in this, we have a lot we can do. We have a lot to what I call do one big doable thing, which is leveraging existing systems we already have in place to optimize primary prevention, which many of those systems are held accountable for, but they don't work together and they don't really engage the family and the child in a holistic way to get the outcomes we need. So that's what the cycle of engagement is about. If you're not familiar with Bright Futures guidelines, they've been around since 1990 and really articulate the best practice recommendations for every age of a child. And these are national guidelines that are linked to requirements for every health plan, and then they translate into a lot of performance measures for our systems. It's actually required through the Public Health Service Act for all health plans and insurance providers to provide services that are aligned with Bright Futures guidelines. And the cycle of engagement well visit planner approach makes it very easy to implement guidelines so that you can focus on actually working with families, getting the data you need locally, and seeing the improvements and not just doing the basics without a lot of time. So there are 15 well visits in the first 5 years of life, which is currently what the well visit planner approach is focused on, although it can be extended to middle school and even adults, that kind of thing. Everyone has well visits in the country, but well visits are important because they're a point of from birth on to first, of course, look at surveillance and screening and finding out what's going on that might need our attention. Proactive promotion and anticipatory guidance, which most families don't even know what those topics are. And it often is sort of a sideline, and it really is where the juice is for prevention. And then early disease prevention and health promotion, as I said. So this is what we're sitting with. And every city, county, health plan, health system, federally qualified health center are charged to implement these well visits, and yet we see dramatic gaps. And one of the reasons is look at all this. Look at all we're supposed to assess, right? It seems overwhelming. The well visit planner approach that I'm talking with you about today puts this together in a family-facing tool that's integrated, scored with resources based on responses in a 10-minute tool for families to complete, sharing the data with practices or whoever happens to be implementing it, like a home visitor or community health worker, and then they can share the data. So that's the core concept. But if you look at this and people do one by one assessments, often that aren't even scored and made available back to the person doing the assessment. And families see things like developmental screening or maternal depression screening as for the system. They see it as a survey where you're taking data, not actually engaging them. And so there's often not even an awareness of the results. So we all, I think, have studied the barriers. And so we've really been working for a couple decades on solutions that we've tested that work. So again, just for the bottom line, after decades of work, only about 48% of children receive care in this multi-domain medical home measure that the CAMI led the development and testing of, that's included in CAP surveys, it's included in the national survey, and it's really looking at accessibility, family and youth center, coordinated comprehensive care. So we have a long way to go. Our aspirations are high. We even have performance measures, but it's very difficult, which is why we need tools and systems change, like I'm talking about today. So about 1 in 3 kids still today before school, before age 3, actually, get any developmental screening. And even when they do, there's very little follow-up because there's so much time to just do the screening. We can solve for this. And only about 30 to 50% in the beginning actually are going in for the 60 million well visits recommended across all kids 0 to 5 in the country every year, with it being covered by insurance. But I think a lot of families just think it's to get immunized or weighed, and they don't really understand these well visits are to promote the healthy development of their family and their child, and those go together. So we have these guidelines. And some people will say, well, families just don't care. You just said that. It's like, do families know what to expect? They don't know what to expect. They come in, they don't not come in because they don't think it's important. We've done a lot of work studying that, and many others have too. They want to know what quality care is so they can get on the side of getting it for their children, get their own results back from screening, be educated, be linked to resources, but we don't do that. That's what we're solving for in this model that I'm sharing with you today. And some people think, oh, it's enough to send a text to a family to fill out a screener. And if they don't do it, they just don't care. Well, that's not true either. It's hard. There's not a lot of value for families. They don't get their score back, resources, and it's one at a time. It takes lots of time doing it that way versus the way that we're putting it together. But we do know that what we have to do is make space and time in those brief visits that we are getting able to do with the price that's paid for well visits, and even in all of our other systems like Head Start, early care, child welfare, the time is of the essence. So when we use tools to engage families in the very process of assessment, which we have to do, and get the data back in a way that's actionable, where we can really then spend the time listening and caring and counseling and being a support and coordinating with other resources, has huge impacts on family resilience and connection. So this is a study that we did looking at when families experience having enough time, feeling listened to, and getting specific information about their personalized concerns. Their resilience bounces up, their sense of hope, strengths, what to do. And that's really the job we should be doing. So wherever you turn, the engagement mandate is there, the whole person, whole child mandate is there. How can we make it feasible? I'm getting to the details here, but I really feel like I need to set it up. I want to say a couple more things about why it makes sense for cities and counties. So you're all probably familiar with EPSDT guidelines since 1967. They basically Bright Futures guidelines for primary prevention for young children and all children is based on the EPSDT benefit in many ways, but it brings it to life with best practice evidence-based approaches. And right now we have a new guide that came out from CMS on primary prevention and EPSDT that really aligns with everything I've been saying. I really encourage you to read it. I did. I've created 2 slides that are very succinct, but really want to highlight that there's a increased push to get all states and cities and counties to make sure they're really implementing EPSDT to up the accountability for this. It's such a huge opportunity for us to address so many issues early in life using a no wrong door approach, which is definitely what the cycle of engagement well visit planner approach was designed to enable, to engage families anywhere, to share the data in a one-page summary, to be able to then spend all our time addressing what came up and addressing family needs. So the guide is really indicating that for all states, it won't be optional to make sure families know what they're supposed to get, that they have to have ways to oversee, verify, and enforce them. And a lot of our tools and models can help with that. In addition, really pushing for not just on the books engagement, say between Medicaid and Title V and Head Start and WIC and all home visiting and all the systems we have, but really saying you have to do that. We've known that for a long time, but there's a lot of the things that beleaguer the possibility to do that, which is exactly what we're up to here. In an exciting evolution, for those of you who know what Title V MCH block grants are, they go down to the community for supports in many ways. We now actually have child flourishing, like I talked to you about, school readiness and adverse childhood experiences as national outcome measures for public health agencies to embrace and track toward. And these all require cross-sector collaboration and focusing on improving primary care. So lots of alignments and getting right to cities and counties. The alignment is very strong for your Healthy People 2030 goals. Many cities and counties anchor their their county health plans, health improvement plans to these. So everything I'm talking about will definitely improve rates on these key indicators around reading, being able to read before fourth grade, reducing obesity and overweight, and reducing hunger and food insecurity, but also so many of the other objectives that I talked about. So to do this, we have to do systems change. We've all had aspirations for a long time, but we don't rise to the level of our goals. We fall to the level of our systems. And we need that cross-sector systems integration, but it can be so hard when we're talking about how to really operationalize that. So in another full hour presentation for this NATO 2026 meeting, I'm going to take a deep dive on something called the Engagement in Action Framework for statewide, county, citywide early childhood health systems integration. And this framework is actually powered by the cycle of engagement well visit planner approach in the sense that it helps overcome the real barriers to that cross-sector integration. And the good news is there's so much consistency across all of our systems that are really living at the local level, whether it's home visiting or early intervention or WIC or Title V programs. Early care and education, Head Start, of course, Medicaid and health centers and things like that. Very similar. This is just a table visual, very similar activities and goals they're meant to do. And this is a little picture of them. And right now, one of the biggest missing pieces in collaboration is the pediatric primary care or family medicine primary care well visit. So there's a lot of interest in collaboration across the early childhood systems, but very few have really looped in and explicitly coordinated to make sure kids from birth to age 5 get all of those 15 well visits that are high quality, but are integrated so that the the social issues, the relational health issues, the parenting issues, and all of those things that need to be addressed actually can be addressed through this collaboration, and also engaging families through any door so that they can come in through an early care and education or any program and get to primary care, but actually the screening can be done in those systems. So I'm going to talk a little bit more about this possibility, but we have so many resources and the integration is really important, and it's very important to integrate healthcare, which is often left out in the otherwise many stunning efforts in areas to collaborate across other early childhood systems. So the through any door approach, whether a family is going to the community-based or healthcare access, can be a point where they get engaged to find out and do screening and assessment, share the data with each other. And you can see down here that wherever families go, ultimately, there's within the authority of those programs, the idea of engaging, educating, and doing screening for families. But if you do that, and then they go somewhere else, it happens again and again and again. Often it either doesn't happen, the screening, or it happens multiple times and nothing happens. So we're solving for that by creating a tool anyone can use through any door and be able to effectively engage families and share data across systems so that we can share the family's agenda, all anchored to the guidelines, the Bright Futures guidelines. So we can be confident that we're actually meeting our own performance goals while engaging and improving the lives of children and families. So, but there's 4 big barriers that the collaborative groups that we've worked with across all those systems have noted. One is there's lack of standardization in assessments and tools. Once you have information, it's often not scored or reported with any links to resources locally, and it can't be interoperably shared. So I collect it, but then you have to do it again, or it's very messy and not very efficient. So that interoperable data sharing platform that is part and parcel of the cycle of engagement well visit planner approach is really essential, with families approving of the sharing so that we get all that. And then having the real-time capacity is the last criteria to also, as a system or as an individual program, track what's going on. So how do we find out if we're improving in a shorter time frame than just looking at those state measures? That how can we really get the feedback loops? And so the cycle of engagement well-visit planner approach also includes a validated quality assessment tool, also reported by families as a tool for them to encourage them to find out how it's going and partner in improvement. So we've got this model that was intentionally created to overcome the key barriers that we hear over and over for cross-system collaboration. So now I'm going to do a deeper dive into the well-visit planner cycle of engagement approach. So what is it? Generally, it's a personalized relationship-centered model, a family-centered integrated approach, a measurement process, and a population health strategy. It's got 3 elements: the well-visit planner 10-minute online tool that you use with families before, at home, in the office, on their phone, that sends a report to you and others to then create the personalized connected encounter, which was the goal for all of our work, was to create a personalized connected encounter, which I'm going to describe more, and then on a periodic basis to assess quality and get all that data right back to the clinic, to the community, whoever's sponsoring the use of these tools. This is what the well-visit planner looks like. And it's basically a very simple online platform for families that you set up on the back end with your unique URL and unique welcome message, and you put your logo on it, and helps families reflect and assess. They're not taking a survey, they tell us, prioritize what they want to talk about among the guidelines for topics, which is the goal for Bright Futures, and then have the time to really partner with families and coordinate care. So that's what the tool looks like. It's mobile optimized in English and Spanish. And families basically can click on your link, or they can set up their own account as well. They don't just have to click on a link. They get an account where they have multiple children that they can keep track of. They can store their well-visit guides over time and complete the tool that's for them, get their own results back with a well-visit guide that we designed with families, which they love to keep over time, even to monitor how their child's been doing over time. And they pick their priorities and partner in care. This is a little bit of a picture of the well-visit guide. It's not fancy, but families like not fancy. And also it's short at the beginning with a summary, but then it breaks it down. And families really wanted the detail of what kinds of questions can I ask my provider about this? How can I learn more about this assessment? What are some resources I can use? So we actually have sheets for all 256 topics across the first 5 years of life for preventive services that answer those questions for families in English and Spanish. So why is this topic important? What are example questions I can ask the people I work with, my doctor, my home visitor, and how can I get some resources for myself that are non-proprietary and credible? So this is a little bit of a picture of what the provider or home visitor, whoever's sponsoring this, because it can be sponsored by anyone, community health workers, or anyone can use the tool and be in a position to start sharing it with the others on the family's care team. And so it's on one page, a quick summary, already scored with links to resources. And then the second and third pages go into a deeper dive of resources based on what the family said. So if they did screen, if the child didn't meet developmental screening criteria, there's tips for that, and so on and so forth. So it's a couple pages, but the first page is an at a glance with a big check mark if there's an issue, it's blank if there's not, and if the family didn't respond because they didn't feel safe to, there's an NR in there. So you can be sensitive if for some reason the family didn't want to report on things like domestic violence or alcohol and drug use, but pretty much most of the time they do. We have very few missing values. And all to really do the personalized connected encounter, like I said, where you come in, you have the well-visit planner completed, you can celebrate the successes. The first questions are what's going well, what are you excited about, your child, being a parent. Focus on priorities, ask them, thank them for completing it, ask if they want to talk about what came up on the screeners, what they already know they need to do, and how you can help them. And it's really driven then by the family, which we know is so important. That engagement is letting them take the lead and get activated, and then you're helping them with their goals, and that goes a lot better. And then again, this is just a picture of the Promoting Healthy Development survey that's set up just like the Well Visit Planner. It takes about 12 minutes for families to complete. They get their own scores back. You get an aggregate report after at least 25 families fill it out. You can do it at a community level. It's been used in many state Medicaid agencies at the state level, as well as in national surveys. So it's basically making it really something you could use, like say in a rural health area, you want to find out what's the quality of our well child care. You can start with this, use the Well Visit Planner and your other magical tools to improve, and then come back and see how it went. And this is all aligned with Bright Futures guidelines and performance measures. So I'm going to show you a brief 2-minute video of the Well Visit Planner. This is a family-facing video, and it's very short.
Hi, my name is Barbara, and I'm a family advocate. But even more importantly, I'm a mom, grandmother, and now a great grandmother. I want to talk to you today about the Well Visit Planner. What is the Well Visit Planner? Well, how many times have you sat in a waiting room filling out forms that you didn't even know what they were for? Or walked out of an appointment and said, gee, I meant to ask the doctor about X, Y, or Z. The Well Visit Planner is an online tool created in partnership with families and healthcare providers to prepare you for well child visits. The Well Visit Planner only takes about 10 minutes to complete and puts you in the driver's seat. Not only are you in charge of your family's healthcare information, you also know what to expect during each well visit checkup. The 10 minutes it takes to complete the well visit planner brings your strengths and priorities front and center. So you and your healthcare providers can work as partners for your child's healthy development and well-being.
Okay, so that's just a short little review for families. We have that in Spanish as well. But some of the feedback that we get, and keep in mind, we're not like Silicon Valley funded or anything. We've been doing all this with HRSA, foundations, and it's definitely um, maybe not as fancy as some things, but it works. And I want to tell you a little bit more about the feedback we're getting and some application in primary care. But keep in mind, everything you're hearing about using it in primary care or with pediatricians or family physicians or nurse practitioners can also be true for community health workers, home visitors, Head Start professionals, early care and education specialists and professionals as well. So here's one comment made by a parent who actually was working with a pediatrician even at one point. So they had no idea that they could talk to their doctor about their child's behavior and emotions. And they just thought they were a bad parent, which we see a lot of. A lot of families don't know what to ask about, that it's okay to ask about it. We're not educating them about what's important. And then they feel scared to ask about it. They're going to look like a bad parent. So it definitely drops the stigma, opens up the door, normalizes the discussion about a lot of really critical things. About 92% of families, the last time we formally did a study, said they would definitely recommend it to others. And that they were comfortable with the time it took and felt that it was really a huge improvement. They had no idea what well visits were for. It's also guideline based, so then they feel confident that they know that this is based on the American Academy of Pediatrics, cooperates with the federal government, HRSA, to create the Bright Futures guidelines. Provider input similar. There's so much more I can share with you for those of you who want to know about the research. But the last research we did on implementation with 10 practices, there was 100% of the clinicians involved said that they were much greater satisfaction for them in doing the well visits. About 8 out of 10 would recommend the practices, so they would recommend it to others. And that they'd liked it to continue. And often the issues are really engaging the system within a health system or within a clinic or within an agency to say, yes, we can do some of the jiggering we'd have to do to start to enable the well-visit planner. It's actually not that complicated, but you can't really do it without getting your support from your organization unless that's not an issue and you have freedom to do it, then you can just start doing it right now. Like a rural health provider could just open this up, start using it tomorrow, test it out with a few patients, stop. It's not like an all or nothing thing. It actually can work right now for anyone who wants to use it. But for those of you who are in organizations where they limit what you can do, is a bigger conversation. And often we find that health systems and health plans aren't always prioritizing kids. So that's a bigger issue we can't solve for, but we have a lot of tips for how to overcome that. And we'd love to support you in that. Okay, so a lot of use initially was in pediatric primary care, but we've had use of Head Start and Help Me Grow programs. And of course, all of the systems are able to use it and are using it. We just don't track them all. But this is a little poster. We have lots of posters and postcards and things to share with families to engage them. And I'm going to tell you a little bit about the People's Clinic, which was one of our superstar recent implementations. It's in Austin, Texas, led by Louis Appel. They're a large community health center, federally qualified community health center, a lot of Spanish-speaking Hispanics. So a lot of the use has been with non-English speaking Hispanic families or where their primary language is Spanish. And they wanted to do this because they were having a lot of barriers in their goals to promote early relational health and quality systems that could really promote family resilience, parent-child connection, parent-child flourishing, because there were so many complications in just doing screening. So they're now using Healthy Steps in the Well-Visit Planner, which the Well-Visit Planner feeds the data that you need for Healthy Steps in your electronic record. For those of you who know what I'm talking about, that's important. But really, it's to be able to focus so much more of their time on promoting early relational health and connecting families to resources in a way where they trust and they follow up, and you get to start partnering. They also get to meet practical goals, like with the clinical summary, they can see the results, but also the results can go into the record if needed. And it improves billing for a whole lot of screening that's not even being done right now because of feasibility issues. So there's a lot of billing codes that you can bill for by using the Well-Visit Planner that was just infeasible to do it before in many ways. So there's also a platform that you go to, cycleofengagement.org, and PCC did this in 15 minutes on their own to get it started, registered, customized, engaged, and then reviewed. They get to then review this clinical summary and then partner in care, just like we said. So there's a lot of detail, but when you sign up, you can customize, come back and customize, meaning you have a welcome message, a logo, you can pick some extra screeners and where to put them by age. You can upload your own documents and resources for your community if you want. So families get that in their well-visit guide, like lists of resources for social factors or other things, announcements about your clinic or your community, what you want them to know. So there's a lot of options for customization, but you get a secure dashboard. Now, keep in mind, we do run the National Data Resource Center for Child and Adolescent Health. We have a huge data security agreement with the government that we've done for a long time. Our system is not held by the government, but it is held independently, but very high standards. And all the information is de-identified unless you want to get it back. You can actually get your own data back at the clinic level, identified or de-identified, depending on what your preferences are and the agreements that are in place. So you get a dashboard that's yours. It's well protected. And then if you do the Well-Visit Planner, you get a specific implementation portal that has a lot of resources in it. I'm just going to quickly go over this, but letting you know there's a lot more that you can learn. But basically, we lay out a plan. Once you've decided to use the Well-Visit Planner, you've signed up, you're starting to use it to create your plan. What are the elements? Engage your families, how to get results and use them in real time. partner in care in the clinic, and then keep improving with that PHDS monitoring and improvement work. So I mentioned the electronic record, just a visual here for Epic. We've had it integrated into many. It's not hard. It's never hard, but it's really a matter of prioritization. But right now, um, it's it's built so that the data can be directly imported into Epic at the field level, as well as the clinical summary being imported in and easily accessible. This doesn't solve for sharing data across systems, though. So if you're in Head Start and you want to get it to primary care, our system allows that because most electronic records are not built to create connections outside of the health system. So we got you covered there. So basically, this is a little bit what it would look like if you came on. You'd see the well visit planner option, get the clinical summary. The data is integrated into the forms that are needed as well for tracking. And that really all enables the personalized connected encounter. I know this is a busy slide, but I wanted to make sure you understood that it's always coming back to the personalized connected encounter as the goal, guideline based, so that we can really actually make a difference. This is designed to work with other programs. It's not a substitute. It enables better services for Healthy Steps, Head Start, home visiting, WIC, community-based programs like Help Me Grow or Reach Out and Read. So it creates the whole view summary you need in a family engaged way so that then you can spend more time doing in clinical settings and in the settings you're in supporting families. So it's not competitive, it's empowering. It's meant to generate better results for all these programs. So lots of feedback. We've had many studies. I'm going to let you read the slides if you'd like, or go over it more slowly if you're reviewing this. But the bottom line is it saves time for families and providers, ensures all recommended assessments take place and priority topics are addressed for families. Just that alone is very joy producing, we have found from those who use it. Greater provider and family satisfaction, as I said, as a result of that, and dramatic concrete improvements quickly using measures like the online Promoting Healthy Development Survey and all of the measures that we're held accountable for already, as I mentioned before, like developmental screening, maternal depression screening, well visit rates, and so on and so forth. And then, of course, we do have seen over several times reductions in urgent care where those partnerships are there, families call sooner, they have the information they need, and less urgent care. So with all that, you can access our toolkits, which lay out an implementation roadmap for you. And those steps are generally to phase 1, discover, decide, and design, with lots of resources to help you do that. Phase 2 is team up, get your testing team up, train up, and test up to make sure you get all the bugs out, and usually goes pretty quickly, or it can. And phase 3 is actually begin to engage families at a broader level than you're just testing, partner in care, and really opens up many opportunities to improve the actual system and services, and then keep improving. And lastly is sustaining, which is where we get to that scaling as a way of doing things in your system, tracking, embedding, and spreading, and integrating and scaling. And we would love to work with you on that. So if you are in a different system than just healthcare, or even if you're in healthcare, you want to hear some stories. We're really big into stories, data and stories. These are 10 possibility prototypes you can access and we can give you, looking at every single partner, including family-led organizations, faith-based communities, on how they could actually be a partner in using this, why it aligns with what they're trying to do, and what's working now and how this can help, and what would it look like to do it, and what would be needed. So these are short 2-page stories on how Head Start, early care and education could be a lead to do this work, because everybody can lead in the work of systems change and promoting early and lifelong flourishing. We've had recommendations across the board. Of course, when you're working in early childhood and the return on investment for saving society money due to prevention is hard to get, we're keeping our we're keeping ourselves in the game, but we definitely are seeing this as a health utility with support to make it easily accessible. And so it is at this point accessible if you're interested. And I wish you all the best because you are the leaders on the front lines that city and county partners will lead to scale early and lifelong flourishing for children, youth, and families in using some of these innovations that help you take what I know many of you already know you want to do and really bring it to fruition on the front lines earlier than later. So thank you for your time. I appreciate you, and I look forward to maybe hearing from some of you if you are interested to do so. My email is cbethell@jhu.edu, cbethell@jhu.edu. Thank you, and have a wonderful rest of your day.